It's Mark and Pete.
Hello and welcome to the show. More colourful conversations with Mark and Pete. The show devoted to religion, politics and business. This week's colourful conversation is around the key question: can Britain afford the NHS? The National Health Service, the NHS in Britain, was a groundbreaking service designed in the 1940s to provide Britain all of its citizens with the right to free healthcare and improve effectively its society's care system, both now and for the future. Well, it was a flagship for the welfare state. And as we've seen over recent years, the NHS has come under great scrutiny and criticism for failing to reach targets under the creaking system, a burden of expectation and high demand. So with decades of political sticking plaster policies, have this sort of bandaged deep wounds in the system? And can the system continue to suffer in the way that it's going? What is the future of the NHS? Is now the time for major reforms? So with me today is Pete. So Pete, can Britain even afford to continue with the NHS?
Well, Mark, I think that what we have here is a fundamental question about what sort of society are we? Do we care for our sick? The Bible has many instances where it calls upon us to care for those who are sick, and anyone who is suffering is worthy of our attention, whatever their background, whoever they are. Yes. And so we are encouraged to care for our sick, so we need to have a health service in place, whatever the costs. The question is, of course, is that cost too high? Could it be reduced? Not whether we should do it or not. We should care for the sick. But we are also in the Bible encouraged to pray to God for the sick. So really there's two sides to our caring. One is we should physically help the sick. We should try and help them to get better by caring for them, by looking after them, taking them in, giving them all the medical care that they need. And also we should pray for them. In James chapter 5, verse 13, where it says, "Is any among you suffering?" It then goes on to say, "Is anyone among you sick? Then let him call for the elders of the church, let them pray over him, anointing him with oil in the name of the Lord." And in doing so, in offering people up to the Lord, in praying for them, we're encouraging God to heal them. We are, by God, encouraged to heal and to provide for the sick. And so together, we, between God's action and our action, we are given the responsibility of seeing that the sick get the best treatment, and the aim is to heal them. So, yes, we need to do it. Can we afford it? Yes, we have to afford it. It's part of how we judge ourselves as a good society that we care for the weakest among us, and that's got to include those who are sick. I mean, we have to do it, but how do we do it? And that's the question I guess we're going to address today in the Mark and Pete show. What is the best way to address it? And in the Bible, the way in the Old Testament that it's reported that God's people, when he formed a nation in the people of Israel, the way that they dealt with it, really the giving for sick people was voluntary. There was giving into the treasury of the temple, and giving to the king, of course, to support the government and to defend the nation. But giving for helping the sick, for helping those in need, was a voluntary action, and was done from people to people they knew. And in that, it is different in its nature to the health service we have today. So the question might be put, can we afford the health service? But it might be better be put, should we have the sort of health service that we have today? Healthcare is important, but what is the best way to do it? If you say, well, it's so important it needs to be government funded, then the answer could be, well, actually, you can't have anything government funded, because the only money the governments have, pretty much, is that given to them by taxation. So again, the question comes back. Yes, we should have a healthcare service, but what sort of healthcare service should we have?
Well, exactly. And to that point, as you say, we're all stakeholders in this national health system. We pay our taxes and so on. But the point here is that it's been very much covered in the media that both doctors within the hospitals and throughout the national healthcare system and patients see this as being somewhat frustrating. They've never seen it so bad. Effectively, ailing hospitals plunged into deeper crisis through issues, etc. But I think what we could do is just sort of set a scene where the frustrations, both from a doctor's point of view and a patient's point of view. So this is a little sketch which is entitled Hard Cheese. Doctor, I've swallowed cheese. It's made me cough and start to wheeze. So please leave this painful squeeze and quickly put me at my ease.
In my expertise, you should swallow fleas to eat the cheese. It guarantees to ease the disease.
1 week later. Doctor, I swallowed fleas to eat the cheese, and now I'm wobbly on my knees.
In my expertise, you should swallow bees to chase the fleas that eat the cheese. It guarantees to ease the disease.
2 weeks later. Doctor, I swallowed bees to chase the fleas, to eat the cheese, and now I keep producing lots of breeze.
In my expertise, you should swallow trees to absorb the bees that chase the fleas that eat the cheese. It guarantees to ease the disease.
3 weeks later. Doctor, I swallowed trees to absorb the bees that chase the fleas, to eat the cheese, and now I've got Dutch elm disease.
In my expertise, you should swallow purring Siamese to run up the trees to absorb the bees that chase the fleas that eat the cheese. It guarantees to ease the disease.
4 weeks later. Doctor, I swallowed purring Siamese that runs up the trees to absorb the bees that chase the fleas to eat the cheese, and now my body is starting to seize. What do I do?
There's no reprise from this combined fatal disease. In my expertise, perhaps it's simply best to stop eating cheese. Next.
Oh, the frustration, the frustration. Well, I mean, this is the problem, isn't it? I mean, the patients, again, the simple example there was, of course, just go back to the simple point that clearly you didn't have to eat cheese. But is it that patients are just wasting people's time? Is it that too many people are going to the doctor or to the hospitals for the wrong thing? Are we putting more burden on the system ourselves? There's a point of responsibility, isn't there?
Well, there is that problem. I know that doctors that I've come into contact with and surgeries that I've come into contact with, local groups of doctors, are putting into place systems to try and stop this, or at least ameliorate the problem by having certain conditions addressed by nurses and it not even coming to the doctor's attention, certain routine tasks. But in the end, we've come to view the seeing of a doctor and him being able to simply solve our problems as almost a right. I mean, I think I'm right in saying that. I mean, I don't have any research to back it up, at least not in front of me. There may well be research done, but just simply anecdotally from my own experience, it seems to me that there's an attitude that the National Health Service in Britain is there to sort out all your health problems, and you have the right to go to the doctor and he's going to do it. And this just simply cannot go on. It can't be done. There's no system that could be that good, and it's putting too much pressure, too much expectation on a system that, as you said earlier, is just creaking. It's just not able to cope.
No, exactly. And I think that one of the things that we should do, just to sort of explain to our international listeners about how the NHS came about. So for awareness, the Labour government elected in 1945 made a manifesto commitment to implement the recommendations of the Beveridge Report, which actually took place in 1942. Now, the report recommended at the time to create comprehensive health and rehabilitation services for the prevention of cure of disease. And that was implemented across the whole of the United Kingdom on the 5th of July 1948, and subsequently, of course, the system has grown. The services were initially funded through general taxation, national insurance. That was the additional part of tax that was effectively introduced for the wider welfare state. Now, they were initially as a free point of use, although some prescription charges have been introduced, and that's essentially sort of helped to sort of add and fuel to the burden of economic difficulties. But I think that the problem here should be highlighted, that the fact that in recent times, stats have really shown that the system is creaking. A good example, statistics came from the National Health Service, that just 92.6% of patients were seen in 4 hours, which is below the 95% target, whether that's for Scotland, Wales and Northern Ireland also missed their targets as well. So the point is, although targets are set, it's clear that people are using the system more than the system can actually service. There aren't enough beds, there aren't enough doctors, there aren't enough hospitals, there just simply aren't enough general practitioners to cope. So I guess what we need to focus on is, what is the solution?
Yes, well, the solution does come, as always, from identifying the problem. And you in going through the history of how it was developed and why we're in this situation, you've highlighted a part of the problem, which is that what we have developed as a National Health Service was originally developed from two different approaches to healthcare. One was the hospitals, which were in large part set up as charitable concerns, pretty much always set up by churches or Christian groups in order to help the poor. And then there's the local practitioner, the general practitioner, we call them these days the GP, the local doctor, who would be effectively a business, but a sole trader. He would be an individual performing his role, being paid for by local people. So you had these two different systems put together, and that's why we've ended up with the system we've got. But what people actually access in Britain when they go to a doctor, who will be their local GP, he will then be referred to a hospital or to different practitioners as that doctor sees fit. But what the patient sees is the doctor needs to sort out my problems. And that idea of the I suppose the all-powerful local doctor was never true. But now, with the amount of cost and organisation needed for these quite elaborate treatments sometimes, you simply can't have it being the case that this is run in a two-tier system as the doctors and hospitals. And as well as the problem with expectations that I was talking about earlier, being too high, you're ending up with a system that can't fail but disappoint. Now, in other, we were talking about our international listeners, and in fact, the majority of listeners to Mark and Peter are outside of Britain. So, just to address what their experience has been. Now, I don't know what their experience is. Perhaps you could let us know. It'd be very interesting to know what your experience is of trying to access healthcare at the point of use. Pretty much always, for us in Britain, the first point of contact is a local doctor, and we're expecting them to then refer us elsewhere if necessary, but that's who we see. Whereas I spent some time in the Far East, and in countries there, it seems to be more the case that you go to the hospital and expect an organisation to then point you to a doctor, who has your specialism. So we have what I'm saying is, when we're talking about the NHS, we're talking about the British system, which is that two-tier system. And therein is a problem, but therein may lie the answer, in that the doctors operate very locally. Hospitals, which cover a wider area, can be accessed where their expertise is needed. Maybe there's something in that, somewhere in that, we can find a solution to the problem and, oil the creaking bows of the NHS ship.
Yes, I agree. I mean, the one thing is, though, of course, is that at this moment in time, in my opinion, the system can't continue with the current policies.
Mm.
I don't think there's any dispute that what Britain has clearly shown to the world is having a welfare system with this ability to be able to provide a service to everyone of all standing, right through the class system. The fact is that having a national health service is a good thing. However, it cannot continue in the manner in which it is structured. So, in my opinion, we need to look at this in a different way. I think government has a role. I think also, as you say, the local GPs have a role. But I think that as we're seeing more and more, that private entities to support the national service is something that could be considered. So I'm going to set this up as a point of conversation on this topic. This is a little poem called Bad Constitution.
Okay.
Doctor, doctor, I'm feeling ill. The government passed a new health bill. An emergency forced the measures quickly, and now I'm poor and very sickly. Cuts and slashes with parts misused, my once healthy standing feels abused. For decades my public saw me performing. This tired old body is woefully transforming. Social care is such a curse. I know that life is getting worse. My vital signs are too low and waning, exhausted from a nation's complaining. First born in Britain, I brought a revolution, now unfit for purpose with bad constitution. As an ailing patient found in distress, you've known me as the NHS. So, doctor, doctor, it's no use trying. My public purpose is truly dying. Please rewrite welfare to a farewell state and condemn us all to a private fate. So, my point is going to be this, that I think that we can still look at localism where effectively a local community is serviced by general practitioners, but effectively that companies who have the expertise and the resources effectively are there where services are outsourced. Now we're seeing this where hospitals are bringing in services. For example, I mean here again, just to sort of illustrate the point, that more than 70 Spanish nurses have been brought in to a hospital in the north to help with the struggling casualty departments. And that's both right across Wales as well as Northern Ireland and, of course, England as well. So the point here is that we can utilise resources on that front, but also companies can help to service this as long as it's controlled by the local community. I think as a national infrastructure, I don't think we can continue in this way. And if we do, we're going to either lose the ability to retain staff who are disgruntled, who are overworked, who do not like the system, who don't want to stay in the system. And that's crucial. We don't want to lose expertise. We want to retain it. It's fundamental. But at the same time, we going forward in the 21st century have to find a better way of using the resources that we collect, the taxes that we collect from government, and redeploy it in a more structured fashion and in a way that services the local community better.
Yes, I mean I agree, and I think that there have been strides made in the direction. I mean, we don't always want to be critical of the current government. I think strides have been made in the direction of which you're talking, and that there are local health authorities which do, as you say, bring in expertise when needed. The problem has been in the past that there were unnatural divisions. For example, you'd have a health care trust in charge of several hospitals, and those hospitals were different in the way they operated, in their specialisms, and even in the areas in which they operated. And so it was an unnatural grouping, and so it definitely didn't work. But there's been a move away from that, and it's more now under the current system that you would tend to get a more natural grouping. I mean, it hasn't been complete, this review and change, but it's certainly been a step in the right direction. And bringing in expertise from the private sector has been effective in some areas. Of course, the wholesale giving over of hospitals or healthcare trusts to the private sector hasn't really worked. What you've seen is basically it was like a takeover bid in which a private company can take on what something was quite a big asset and therefore can run it in such a way to maximise profits, but not always to maximise the effectiveness. And at a national level, that has meant that some companies have managed to take over a certain type of treatment. I'm not going to give specific examples, or I could name them from the research I was doing in preparing for this show. I found various different examples. So I'm just going to say generally, I mean, the information is all out there. I've not done any special research other than ask a few people I know who work in the NHS and look at generic search engines results. All I can say is that for treatments of certain diseases, for certain high-cost diagnostic techniques, companies that have managed to get hold of the rights to provide to NHS authorities and healthcare trusts, and they're not the best ones to provide it. So we've seen abuse of the system, is what I'm saying. But there's still been steps in the right direction. And what I would say, I think this is where you and I agree, Mark. I think that what we do need to see is a move to more localism, make it smaller and therefore more accountable. You can see what's happening. Where something needs to be done by a big company because, that's allowing you to have an economy of scale, like, for example, production of a specific drug. Well, we already have private companies doing that. Think of the large drug companies, which are multinational, but they are bought in by local health trusts or a local health authority. You don't see them, being controlled by the companies. It's them controlling the decisions that are made. And so what I would say, this is where I think we differ. I would say, yes, you do want to see a small scale provision of healthcare at a local level, buying in where necessary. But I would say that the control of that would be better to be run by healthcare professionals who are employed by a democratically elected body. So I see the way forward being local, and I mean very local, smaller than you would commonly see a healthcare trust being maybe a big city hospital or a couple of big city hospitals. A small local area having its own healthcare trust. About the size, I'm talking about the size of, say, a couple of wards in a local council. That sort of size, grouping together basically areas in a city or in the countryside, grouping together, and they have their own, basically a committee, a group of people from the area who are responsible for making sure that people are cared for. Now, they're not the people who are providing the expertise. They're buying in the expertise, but they're in charge. So I'm not criticising completely the current system. What I'm saying is it should be smaller groupings to make it more local, to make it more accessible, so more visible to the people who are actually using it. And thereby you have setting up a system, a way of operating in which accountability is greater. So I'm not criticising completely the efforts made by this government or previous governments. I say they've had, some good ideas. It is a difficult problem, but getting it smaller, easier to manage, more local is the way forward.
Yes, but I think that to that point, I think that, of course, now here we are in the 21st century, the system has clearly suffered from chronic under-resourcing. And I just wanted to raise a point that was highlighted in the media recently. So Adam Brooks Hospital in Cambridge came into the public media recently, where Dr. Keith McNeil said that the NHS should be re-engineered to prevent crisis, and clearly there have been some problems. And one of the things that he cited in particular, which really plays into the point that we're making here, is that one of the reasons for the increase in the burden is the fact that we are getting older, and there are more people who are older, and clearly as a result of living longer, the aging population means that there are more people who are, for example, over the age of 85. And what was cited here is that they were using, say, 300 beds out of the 1,000 beds that they've got, that people who are over 85. Now, that's quite a high proportion. And of course, if you've got a more localism approach where you can assess effectively the demographics, you can assess what is required for those people who are clearly perhaps moving further beyond the average age expectation, which clearly as it's year by year is getting higher and higher. That means there's going to be more burden on the system. But I think taking a slightly more dynamic approach in terms of reassessing the localism of what is required, rather than just simply having a national system that is meant to cover for everybody, in which clearly it can't do the way it's servicing at the moment. There are too many people who are turning up to hospitals, waiting in corridors, waiting for hours and hours to be serviced, and even, crucially, where, should we say, particular surgery, critical surgery, is being delayed because it can't cope with the numbers.
Yeah, I mean, I think that's a good example that you just put up there. Someone being left in a corridor. Now, who would notice that they've been left in a corridor? Well, the parents, the family, or other relatives of the person, people who know them and care about them. And if you have things local enough, people feel that they know them. They're local people. They will be noticed. Whereas if you have a monolithic structure, if you have a huge organisation, people get missed. People get regarded as numbers or as simply cogs in the system, and they're not regarded as people. You don't really know them, and that's why one of our buzzwords here at Market Beat, localism, is so important in this particular area. It's vital that we get the health service, yes, provide some of the things provided by big companies and provided by huge hospitals, but the control is at a local level. Decisions are made at a local level. You have GPs making decisions for their individual patients. Taking that sort of model, the model of them being local, that is, and having a small healthcare trust, or as you were talking about, Mark, a company taking responsibility for that local area, whichever route you go, whether you go the private or public, keeping it local so people know who these people are, so you're less likely to miss out on people, or to miss people out rather, because you know them. And even if you don't, you know people who will know them. You've got the motivation there not to ever treat people badly and to go the extra mile to make sure that people are cared for. This is not just localism, it's realism. This is what we're like as human beings. If we know people, or if we're likely to be caught out because other people know them, we're more likely to behave well. And, I'm not criticising any particular part of the profession here. I'm just saying we're all human, and it's going to work better if we treat people in a human manner. That's if we get to know them, we work better with them.
Yes, exactly. And I think to that point, it's inevitable that delays will happen when there is no support in the community, whether that's through social care teams or the health service for patients who do require the help. So having that infrastructure, and I think with subsequent governments, as we look to the future, if they were to start to think on a more local level, as opposed to the current policy of system, then I think that we will probably be better served. And of course, this isn't something that's just to address the problem today. We've got to think of the original concept of a national health service for generations to come. What we're talking about here is, yes, to solve the problem today, but think of our, children of the future. Think of those people who will run the nations in the future. So I think that it's basically building those blocks for having a better society where people still want, obviously, a national health system and a welfare system. And I think in principle that's a good thing. But I think localism is the way to go.
Yes, and I think on top of that, on top of saying localism is the way to go, localism means local accountability, means you are responsible for your neighbour, means you've got to care for your neighbour. And so if we're saying, well, the national health service isn't working, we want a local health service, then we need to go even more local, I believe, and say, if we see someone in need, we should be caring for them. It needs a change of heart from our point of view, and I include myself in this. Always assuming that it's the doctor's responsibility to sort out when someone is ill. Yes, the doctor is part of the treatment. The doctor is the expert. But we need to have a responsibility for people we know. And where I live now, I hardly know my neighbours. As I was just saying this is me thinking aloud. I need to be able to care for the people around. I should make more of an effort. We as individuals, the ultimate of localism, individuals, need to care for people around us. From that comes the desire to have a health service that really cares for the people we know around. And so if we structure our health service around that, it's going to work better as long as we really do care for our neighbours.
Yes. So with that, we invite you, listener, to let us know your experience of dealing with the national health system. Have you had a good experience, or maybe you had a bad experience? What do you think is the best way that the government and, in fact, the whole nation should do to address the current system? Do you think that Britain can afford the NHS? So join us again for more colourful conversations with Mark and Pete.